Good afternoon, everybody. Welcome to the deep dive. It's Bridget here. I'm just going to be introducing Prof. Chapanduka, who will be our chair today, and running through the housekeeping rules, and then I'll hand over to him. Our talk today is on the hematological complications of HIV. Jonathan Oxley and Prof. Jessica Opie will be speaking. In terms of housekeeping, recordings can be found on the Blood SA website. If you go to resources and deep dive, you should find all of the recordings there. During the session, if you have any questions or comments, please add them to the chat box and our chair will go through these with you at the end. In terms of the mailing list, please email requests to be added to the mailing list to Melanie Davids, her email address is there on the screen. CPD points will be submitted by Melanie to the HBCSA. You should be attending with your own Zoom account in order to qualify for CPD points. If you have any queries, please contact us again. And in terms of being able to qualify for these points, you'll need to attend the deep dive for an hour. We also value your feedback after each session. Please complete the survey at the end. It will pop up automatically. It is anonymous, so we encourage you to be honest. Constructive criticism is always helpful. We have the HemOnc conference coming up in the middle of next month, 16th Annual Hematology Oncology Symposium. From the 13th to 15th of September. So if you haven't already registered, please do that. This is our management team for the deep dive. And I'm going to hand over to Prof. Chapanduka to introduce our speakers today.
Thank you very much. Good afternoon, everyone. And welcome to today's deep dive. We've got very interesting talks lined up. Dr. Jonathan Oxley is going to present a case, and then Prof. Jessica Opie will discuss the whole subject. Let me start with Dr. Jonathan Oxley. He's a UCT graduate, and after graduating, he did his internship and some work at Livingstone Hospital in the Eastern Cape. After that, he went on to get his fellowship in internal medicine, the FC Path of South Africa, and a Masters of Medicine from the University of Walter Sisulu University. He's currently a fellow at Groote Schuur to do his clinical hematology. I think many of us are familiar with Jonathan. So Jonathan, please go ahead. We are waiting for you.
Great. Just want to check that I'm audible to everyone, that my slides are on.
And visible, and the slides.
Okay, fantastic. Okay, well, thanks very much for the opportunity to share this introductory case presentation. And yes, hi.
Sorry, we can't see your slides. I had to kick you off to reshare the intro slides.
Okay.
To reshare, please.
Sure. Okay. Okay, am I back on?
Looks good, thank you.
Okay. Okay, great to be here with you all, and I'm going to kick off our session on the overlap between HIV and hematological conditions, and I've entitled my presentation Blasting the Burkitts. And essentially, this is a case that we saw early on this year, and it's quite an interesting case for a few reasons and highlight some points that we really want to bring across, not only to the hematology community, but to anyone else that's listening too. So it revolves around Mr. O.M., who's a 25-year-old male from Rocklands on the Cape Flats. He's a final year mechanical engineering student. And at the time of his presentation to us, he had no known medical history. He did have quite a colorful history in terms of substances. He was still smoking cigarettes at the time that he saw us, but had a remote history of polysubstance use that was quite intense. He had 2-year use of cocaine and ecstasy at the age of 18. He also had a significant family history for hematological disease, with both of his aunts having what sounds like either leukemia or lymphoma. So his problems really started in August 2023, when he noted that he had lumps on the left side of his neck and in his left axilla. And initially, the lumps weren't large and didn't really bother him that much. But over time, they grew in size, and other symptoms began to accompany them. So by the 15th of January, he had significant loss of weight of approximately 10 to 12 kilos. He also reported night sweats, and due to an episode of abdominal pain, presented to Mitchell's Plain Hospital. The initial workup at the outpatients department really only involved some basic bloods, a full blood count and UNE, which was normal, and an HIV test. And the HIV rapid test was unfortunately positive, and the confirmatory ELISA was also positive, and his CD4 count at the time was 274. 10 days later, he followed up for the continued plan of the management of his lymphadenopathy. And because of his HIV status and his loss of weight and night sweats, he had a sputum gene expert. But I'm really happy to report that the message is getting out there. Instead of having multiple FNAs over a period of a couple of months until getting a histological biopsy, he had a core needle biopsy only 10 days after his initial presentation. And the thinking of the doctor at the time was that this was a 25-year-old man, previously well, presents with neck swelling and gastritis symptoms. I'm thinking about TB and lymphoma, and he did a core needle biopsy. So this is excellent. This is really music to our ears, especially to Professor Stelferberg. And the reason for that is because this makes massive difference to patient outcomes. We don't see multiple lymph node FNAs in this patient, which often delay diagnosis. And as I said before, only 10 days from the time to presentation, which is pretty good. Could even be better, but is not bad, considering other patients that we've seen where the delay is months, and often they present at a much more advanced stage of disease. So the diagnostic lymph node biopsy consisted of 4 cores, the longest of which was just under a centimeter. Here's the H&E, both in low power and high magnification. And what you can see on the low power are these this diffuse sheets of infiltrate of uniform cells that all intermediate size, and there are areas of actual focal necrosis that you can actually see on the low power, but even better on the bottom right image, which shows this necrosis. And you can see the characteristic starry sky appearance, which is due to the tingible body macrophages, which have engulfed necrotic material. The CD20 stain was diffusely positive, and you can see it there staining the malignant cells on the right. The CD10 also diffusely positive. The Ki67 was approaching 100% in this patient. And importantly, the BCL2 was negative. And this is important just in the differential diagnosis of these patients, because double hit lymphomas, which can be MYC and BCL2 positive, is something to be considered in these high-grade lymphomas that are very aggressive. And then the EBA stain was diffusely positive, as can be seen here. So in light of this immunohistochemistry, our pathologist diagnosed this patient with Burkitt's lymphoma. Now, under ordinary circumstances, we'd like to make double sure of this diagnosis, not just on morphology and immunohistochemistry, but with the fluorescence in situ hybridization, looking for the translocation, most common one being the 814 translocation. Unfortunately, in this case, for some reason, this seems to have fallen through the cracks. But despite that, the diagnosis of Burkitt's was made, and we treated him as such. So in terms of staging, we did a staging CT, and he had Lugano stage 2 disease. The bone marrow biopsy showed no evidence of malignant infiltration or any evidence of disseminated TB. The CSF flow cytometry showed no evidence of lymphomatous infiltration either. So our assessment was this was a 25-year-old male with a good functional baseline, an ECOG of 0, with a strong family history of hematological malignancy, now presenting with newly diagnosed HIV and stage 2 associated Burkitt's lymphoma, most likely. and with a Blippy score of 0. And again, just to emphasize the benefit of a rapid access to a core needle biopsy, and to say that if anyone wants to learn this skill, please contact us. And this would be great if it was a skill that all doctors knew how to do. It's actually really simple, but can make a huge difference in a patient pathway. So what are the treatment principles that we employed in this patient? So first of all, we started with the steroid prephase. We started on allopurinol to mitigate tumor lysis risk. However, the LDH wasn't that high at the start of treatment. And we commenced HIV treatment and excluded viral hepatitis, as he was going to be exposed to rituximab. And then we embarked on specific treatment for the Burkitt's lymphoma. Now, at Groote Hospital, for our early stage HIV-associated Burkitt's patients with no abdominal disease, we use the modified Milano protocol. And so this is actually quite an old pediatric protocol that has now received, in a sense, a new name. It's basically a protocol that is very dose dense, short-term therapy, only 45 days in duration, but that has very good outcomes in patients of up to 70% for Burkitt's lymphoma in early stage. So this is what we use for this patients. And here's just a little bit of some info on what chemos were actually used in this patient over the 45 days. So you can see how intense this is. Patients spend most of their time in hospital. We sometimes give patients a short break midway through, or pass outs over the weekend, when they're not very deeply neutropenic, which is not a lot of the time on this protocol. But yeah, so it definitely did work, but it wasn't without its complications in this patient. So the patient did develop an episode of neutropenic sepsis with a sensitive Klebsiella pneumonia, which was successfully treated. And he had methotrexate-induced liver toxicity, giardia, lambdia, diarrhea, and massive weight loss during his treatment. So I remember seeing him on one of my visits to the ward, and I just couldn't believe it was the same patient. But in the end, he actually did pretty well. And an end of treatment PET scan after 6 weeks of treatment showed that he had no evidence of metabolically active disease. And essentially, he had a complete metabolic response. And hopefully, our patient is cured. So a summary of the case is that this is a young man with early stage HIV-associated Burkitt's lymphoma that's successfully treated with a short duration, dose-dense chemoimmunotherapy protocol. And the learner points from this case are really that expediting a tissue biopsy is really key in these patients. Just because they're HIV doesn't mean that it's TB. So we really need to get a tissue biopsy to diagnose the potential lymphoma. FNAs delay diagnosis and are not the best investigative tool. And intensive treatment can lead to very good outcomes, but you really need to watch for numerous treatment-related and infective complications that these patients might develop. So with that, I'm going to hand over to Professor Opie to take us through her wealth of wisdom on HIV and hematology.
All right, thank you very much, Dr. Oxley. That was quick and very informative. Let us then move on to Professor Jessica Opie. Prof. Opie has got 20 years of service at Groote UCT and the NHLS. She's a very keen teacher, if I may add, very able at that. And she teaches well both the clinical and the hempath aspects of the subject. She's a widely published researcher and also highly cited. And I can myself say I've quoted Prof. Opie's HIV work on a good number of occasions. And I would advise all of you, if you are interested in the subject of HIV and hematology, just to go through a publication list. You'll find something that will be relevant and of interest. Now, talking relevance, when COVID came, Prof. Opie found herself in the mix of basic research, vaccine research, and research into the clotting problems associated with COVID. Prof. Opie is an examiner for the colleges of medicine, and she has convened many times and moderated many times. And this is for clinical hematology, clinical pathology, and hematological pathology. From a personal view, I express my happiness and gladness that I work closely with Prof. Opie from across the Boerewors curtain where she operates. So Jessica, take it away.
I'm so sorry. Thank you so much for that
There you go.
very generous introduction. I'm going to just find the talk quickly. All right. So thank you very much for this very generous introduction. Indeed, it's my pleasure to work with Professor Chapanduka from the northern part of the Boerewors curtain. And thank you very much to the organizers for inviting me to speak today. Really, I thought what I would do is give a very broad overview of the hematological complications of HIV. And I've based this on a review article that I worked on quite recently and published with my colleagues here at UCT, which included a review of the articles coming out of sub-Saharan Africa on complications of HIV. Okay, so where are we with HIV? There is a huge global burden. Almost 40 million people estimated to be living with HIV at the end of 2023, and most of those are in Africa. In South Africa, we have more than 8 million people living with HIV, and the majority of those are women, and in fact, women of a young age, between the ages of about 20 and 35. There is also a significant number of children under 15 years of age, estimated about 250,000. Antiretroviral therapy rollout commenced in 2004, so it's 20 years now since it's been available. And there has been certainly improved availability, which is correlated with improved survival and reduced HIV transmission. And this is a very interesting graph, which I just downloaded yesterday from the WHO. And they've got a goal, they call it a 90-90-90 goal, where they want 90% of people living with HIV to know their status, 90% of them to be on antiretroviral therapy, and 90% to have a suppressed viral load. And it's actually quite impressive how good the results are. This, by the way, is East and Southern Africa. I think it's a little bit less for us in Southern Africa, but nonetheless, the figures are looking quite good. So almost 95% of HIV, people living with HIV know their status, and the vast majority of those are actually taking antiretroviral therapy. So what are the hematological complications of HIV? And of course, these occur both in the context of antiretroviral therapy and without. The three main categories are cytopenias, malignancies, and coagulation disorders. I'm going to literally give you a bird's eye view of each of these. We do not have in this forum, just an hour. We can't cover all these in depth, but hopefully I can just give you an overview and some ideas of perhaps if you want to look into it further, read around these topics further, and I'm sure that you are all confronting some aspect of this in your daily work. Okay, so I'm going to do anemia, leukopenia, thrombocytopenia, the two main severe types, ITP and TTP, drug-induced cytopenias. I will cover bone marrow production defects, which primarily are due to opportunistic infections and malignancies. I will then go through briefly the malignancies associated with HIV and disorders of coagulation. So the commonest complication by far of HIV is cytopenias. and that is usually anemia. We know that this is often multifactorial. These patients have often a number of different aspects which could be contributing, including the HIV itself, the drugs they're taking, possibly opportunistic infections. And we know the prevalence of these cytopenias, including anemia, increases with advanced HIV. So up to 70% of patients who are not taking antiretroviral therapy are anemic, in quite a few studies. And these are all studies that are focused on from sub-Saharan Africa. And usually this is moderate to severe prior to therapy. When there is more severe immunosuppression, and by that I mean a CD4 count of less than 200, and particularly if patients are receiving Bactrim, then the cytopenias become more common. This is a very nice diagram which comes from the University of Pretoria, from Durant and colleagues, which was published a few years ago in the South African Medical Journal. And it's a graph of each of these dots is a study. And it's reporting the prevalence of different cytopenias in HIV-infected treatment-naive cohorts. And the black line, the horizontal line, is the median. And the blue dots are for their own local clinic. This is in Yesterus Community Health Clinic. And what's interesting here is, firstly, there's a very wide range, but about 30% median are anemic, around about 15 to 18% thrombocytopenic, and about 10% neutropenic. Okay, so we all know that HIV infects T cells, which express the CD4 receptor and co-receptors, by the way, these two different co-receptors. Important to remember that CD4 is also expressed on other cells. It's expressed on monocytes. And in fact, HIV has also been shown to infect other cells, including megakaryocytes and microvascular endothelial cells, and other cells in other systems, for example, astrocytes in the brain, etc. And HIV then causes chronic activation of the immune systems. So with the antiretroviral therapy, the CD4 count comes up, and in many instances, the cytopenias are resolved, but the immune system continues to be stimulated by HIV, even for patients who are on antiretroviral therapy. If patients do not respond to antiretroviral therapies in terms of cytopenias, the things that need to be considered are opportunistic infections, viral loads, drug resistance, and of course, compliance. So this is a graph that we put together for this review article, just trying to have a broad approach to cytopenias. And in fact, this applies in the setting of HIV and without HIV. So broadly, could either be due to a bone marrow production defect or increased peripheral loss or destruction. And I will be going through these different aspects briefly, as I said, the main infections, malignancies, drugs, and of course, anemia of chronic disease due to the heightened cytokines in patients with HIV. They have anemia of chronic disease. And then increased peripheral loss, which can be immune-mediated ITP or autoimmune hemolytic anemia, microvascular hemolysis, GIT blood loss, and or hypersplenism. So what happens to the bone marrow in HIV, and why do patients with HIV have a bone marrow production defect? So we know that the bone marrow niche is a complex multicellular microenvironment. Its primary function is maintenance of hematopoietic stem cells. It consists of bone matrix, endothelial, stromal, fat, and neuronal cells, and it influences stem cell quiescence, self-renewal, and differentiation. It also influences homing of stem cells to niche regions and stem cell mobilization into the circulation. And what HIV does is actually reduces the cellular renewal in the bone marrow niche. It increases stem cell quiescence, so the stem cells become lazy, and it reduces the number of hematopoietic stem cells. So in the patients, these patients with HIV-induced cytopenias or HIV and cytopenias, they are typically on a number of different therapies as well, which adds to the diagnostic challenges. So the current first-line antiretroviral therapy in South Africa is called TLD, tenofovir, lamivudine, and dolutegravir. And I will go in another slide in a minute to show you what they can do. But remember, they are also receiving prophylaxis for common opportunistic infections, which of themselves can also cause complications like INH, can lead to the sideroblastic anemia, which we're also familiar with. In fact, really, it can also cause a pure red cell aplasia on its own, and also severe neutropenia. Rifampicin is a well-known cause of thrombocytopenia, and Bactrim can cause a megaloblastic type anemia without a B12 or folate deficiency. Okay. So in this slide, we've put the different drug classes, the types of drugs that a patient who is being treated for HIV may be receiving, and they would include the antiretroviral drugs, specific antiviral drugs for opportunistic cytomegalovirus infection, sulfonamide prophylaxis, antituberculous, antifungal, and then of course they may be having chemotherapy for a malignancy as well as anticoagulation. And each of these has potential complications with cytopenias. So I'm not going to go through each one of them now, but this is just quite a handy sort of summary of what these different drug families can do. Just to highlight the pure red cell aplasia, which is now well recognized with the with lamivudine and emtricitabine. So anemia is not always due to HIV. They can have the pure red cell aplasia, which is marked by a reticulocytopenia, and of course the parvovirus PCR would be negative. Just highlighting a few of them here, a few of the side effects. Okay, so thrombocytopenia can occur at any stage of HIV. It can be the presenting feature of HIV. And the commonest cause is immune thrombocytopenia, and that is due to an HIV-induced autoantibody, which cross-reacts with a platelet glycoprotein epitope. Again, antiretroviral therapy, which is a rule of thumb for any of these HIV-associated complications, is standard therapy, and then treatment for ITP according to the ASH guidelines. And generally, a bone marrow is only needed if ITP is treatment refractory or if there are atypical features. Remembering, of course, that it needs to be differentiated from thrombotic thrombocytopenic purpura, which is potentially lethal, and it has different clinical features, has typical red cell fragmentation on the smear, which we should not be seeing in ITP, and has TTP has other laboratory findings of hemolysis. And here is a picture of one of our patients, HIV patients, who had TTP with severe thrombocytopenia, numerous red cell fragments, polychromasia, these big blue-gray cells, and some nucleated red cells circulating. What about non-specific bone marrow findings in HIV? So the commonest is dysplasia. We call it HIV-associated dysplasia. But remember, this is not the clonal myelodysplasia that we think of. This is just the morphological features that are seen in these patients. And in fact, of course, HIV is always something to exclude in a patient who has dysplasia in the marrow or blood smear. So there was a very nice study reported from Dr. Chetty and Prof. Chapanduka a few years ago, where they looked at, one of the things they looked at was dysplasia, and they reported about 60% of their marrows had dysplasia, and about 35% was single lineage, but a quarter multi-lineage. We did a study quite some time ago now, about 14 years ago, where we found slightly higher percentages, of course, remembering that the rollout of antiretroviral therapy has also improved over the years. So one can't really compare, but it just gives you an idea of how common these features are. And of course, non-clonal plasmacytosis is almost to be expected. These patients have increased macrophages and eosinophils. They often have hemophagocytosis. And in the Tigerberg study, they reported in 8% of their patients, and the criteria here for HLH were not fulfilled. And then, of course, lymphocytosis, also very common and can be interstitial or in lymphoid aggregates. There's also often a non-specific increase in reticular fibrosis and variable cellularity. Most of the time normocellular, but there can be hypo or hypercellular as well. Non-specific features of severe systemic disease may be present, presenting as gelatinous transformation in the bone marrow aspirate with serous atrophy or bone marrow edema on the trephine. So here are some images to show this is a bone marrow aspirate, and here we can see very megaloblastic erythroid precursors, large binucleate nucleocytoplasmic asynchrony, and a giant granulocyte or metamyelocyte here. And then megakaryocytes. So this is typically we see bare megakaryocyte nuclei, hypolobated forms. Here you can see that the nuclei here are separated, so separated nuclei. These are all features of dysplasia, and by the way, can be seen in other causes of dysplasia as well. On the bone marrow trephine under low power, it's typically disorganized. There's blunting of the fat spaces, and just slightly higher power view of the same slide. Again, the atypical megakaryocytes, and there's an interstitial increase of plasma cells, which you can't see from this distance. Opportunistic infections in HIV are common. The commonest is Mycobacterium tuberculosis. And here is an example of an HIV patient who had fevers and cytopenias. And here we have an ill-formed granuloma with a multinucleate giant cell. And the Zeal-Nielsen stain has very nicely highlighted acid-fast bacilli. Of course, we do not always see these, and their absence does not exclude the presence of TB. And one thing also to mention is that the bone marrow aspirate culture needs to be performed concurrently, because the information on species and drug sensitivities needs to be confirmed on culture. This is TB's cousin. This is Mycobacterium avium. And you can see it does have a different appearance on the H and E. The granulomas are typically less well formed. Again, you can have these multinucleate giant cells. But the characteristic finding is these histiocytes absolutely packed full of AFB. So very different to a Mycobacterium TB, where you only see one or two or perhaps none. Here you really see a lot of bacilli. Fungal infection we see much less commonly in HIV. This is an example which was published actually from Vietnam. A patient who was on long-term steroid therapy and presented with an abscess which didn't grow, and then the hematologist decided to do a bone marrow biopsy for fever and cytopenias, and they found, this is the aspirate, these histiocytes full of round yeasts, and typically in histoplasmosis the yeasts are round to oval. They have a small purple or pink nucleus, and they have a halo surrounding the spore. So these can really be seen with our routine stains, but if you want to highlight them, then a silver stain is very helpful, or in fact a Paz stain. Parvovirus I've already mentioned. It's another cause of, or probably the commonest cause of pure red cell aplasia, particularly in HIV. And of course, we don't need to do a bone marrow biopsy to diagnose it, because it can be diagnosed on PCR. But the bone marrow does have very typical and very sort of dramatic changes. So there are these giant pronormoblasts, really enormous, with deeply basophilic cytoplasm, which is often vacuolated. These huge nuclei with large inclusions. These are actually viral inclusions in parvovirus. The virus is latching onto the P antigen in the erythroblasts and causing their apoptosis. So there is no maturation to maturing forms, and there's a complete erythroid maturation block. On the bone marrow trephine in these patients, these very, very large cells, it looks like huge nucleoli, and in fact, the glycophorin is an excellent stain to highlight these erythroid precursors. Okay, so I'm going to move on now to hematological malignancies in HIV. And they can be grouped into the non-Hodgkin's lymphoma, Hodgkin lymphoma, myeloma, and solid tumors. And I will be going through these in a little bit of detail, just to point out that the commonest in the HIV setting would be diffuse large B-cell lymphoma, and this is from our local data in South Africa, followed by Burkitt, followed by Hodgkin's, and then plasmablastic. So I haven't put them in order here of frequency, but just separated them according to the different types of malignancies. And typically, diffuse large B and HIV would be with more severe immunosuppression, whereas Burkitt and Hodgkin's with less immune suppression, although this data is a little bit different for us here in South Africa. So this is an important article that came out in the New England Journal of Medicine in 2018, and they did a big review of the standardized incidence ratio of different malignancies after combination antiretroviral therapy in the United States. So, and they've divided it into AIDS defining and non-AIDS defining. And to point out here that non-Hodgkin's lymphoma, and this is the high-grade non-Hodgkin's lymphoma, still has an 11.5-fold increased incidence despite antiretroviral therapy. Remember that before antiretroviral therapy, Burkitt lymphoma, for example, had more than 100-fold increased incidence, and high-grade diffuse large B similar, so it's come down to 11.5. Hodgkin lymphoma is still markedly increased in the era of antiretroviral therapy, 7.7-fold increased incidence compared to the general population. Also important to note here is the other malignancies. So Kaposi sarcoma is very common, but it's less commonly seen by us in hematology. But we mustn't forget the other tumors, the solid tumors. And all of these, most of them have a co-infection, an etological virus, most commonly Epstein-Barr virus, but some such as cervical cancer, human papillomavirus, and then HHV8. They haven't got plasmablastic lymphoma on this list because I don't think they have seen that many cases, but certainly I will also be talking about plasmablastic lymphoma. So diffuse large B-cell lymphoma is the commonest malignancy in adults globally, and it's also the commonest HIV-associated lymphoma. We know that it's very heterogeneous. It's not actually one disease. It's many different diseases. There are various morphological variants and molecular subtypes. Most simply, we can use the Hunt's algorithm to differentiate diffuse large B into cell of origin. So using the cell of origin classification and just a few stains, we can figure out whether the malignant cells arise from the germinal center or the activated B cell, which is post-germinal center. We know that for diffuse large B, as I said, marked immunosuppression, so CD4 count of less than 100, and prolonged viremia greatly increases the risk. So here's an example of a bone marrow in diffuse large B-cell lymphoma. This is the peripheral smear. So these cells are large. There are about at least 4 mature red cells inside. So these are large malignant B cells, typically appearing resembling immunoblasts, and often they have more basophilic cytoplasm with some vacuoles. This particular one doesn't have vacuoles. And this is an image from the bone marrow aspirate. By the way, this is not one of our patients. This is from the ASH image bank. And you can see these numerous, very, very large cells. That's a normal erythroid precursor, and this is the size of the malignant cell. So this is diffuse large B in the bone marrow aspirate, and a higher power magnification view. This one's multinucleated with nucleoli, very enormous cell over there, and bone marrow trephine, where you have diffuse infiltration of these very large, pleomorphic, anaplastic, aggressive-looking cells. Okay, so what have we found locally? So there was a very nice study done, in fact, by Dr. Sumaya Kasim, who is now working across the Boerewors curtain with Prof. Chapanduka. And she did this really excellent IMMED, which was published a few years ago in the journal Pathology. So looking at diffuse large B-cell lymphoma in one of our cohorts, so a retrospective study over a 14-year period, and looking to see what is the cell of origin. Is there a difference between HIV positive and HIV negative diffuse large B? And what about EBV, virus infection and survival? So they had 50 HIV positive diffuse large B cases in the cohort, and they actually found an equal distribution of germinal center and activated B subtypes in HIV positive versus negative. They didn't find a very high incidence of EBV. It was only 16% in the HIV cases and 7% in HIV negative, which wasn't significant. And in fact, the patients with CD4 counts of greater than 150 had similar survival to HIV negative. And there was no difference in survival according to the cell of origin, which was unexpected, because normally from the literature, we would expect that the post-germinal center would have a poorer survival. Treatment of HIV-associated diffuse large B-cell lymphoma. Don't know what these lines are that have suddenly appeared across the screen. So the general rule for any of these lymphomas is to start antiretroviral therapy and infection prophylaxis. And for HIV diffuse large B, similar chemotherapy is used as for the general population. And in sub-Saharan Africa, the feasibility of a higher dose chemotherapy has been shown, even in Uganda, for example, where they have successfully given CHOP and DA-EPOC regimens. And we have shown that, or in sub-Saharan Africa, we have shown that for CD4 counts of greater than 150, survival approaches about 50% at 3 years. But when the CD4 counts are lower, the median survival goes down to 6 months. Okay, so Burkitt is highly aggressive, much more aggressive than diffuse large B-cell, and Jonathan presented a very nice case at the start. Remember that lymphoma and leukemia are essentially the same disease, except that in lymphoma it's localized, and with leukemia it's disseminated. And as he mentioned, there is a characteristic c-MYC translocation leading to uncontrolled proliferation. And these are the typical cells. So they're smaller than diffuse large B, typically intermediate in size, so about the size of 2 red cells, with very deeply basophilic cytoplasm, vacuoles also which overlie the nucleus. And this malignancy has a very high, this is the most highly aggressive tumor with a very high proliferation index. So we also had a look to see in fact, we were seeing a lot of Burkitt lymphoma and leukemia in the hematology laboratory, and we decided to do a review. This was also part of an MMed project, which we worked on. And it was interesting because what we found in a review of 49 newly diagnosed Burkitt patients, 61% were actually leukemic. So that's a high proportion that were actually diagnosed in the hematology laboratory as opposed to in the anatomical pathology. So, you know, hematologists really need to know about Burkitt. It's very common, and it's a hematological emergency. It needs to be treated very quickly. In our group, the median CD4 count was 240, as expected. They had 20% had a complex karyotype, so not only translocations involving c-MYC, but they had other associated karyotypic abnormalities as well, and quite a poor 5-year survival of 34%. So Jonathan showed you the lymph node biopsy from his patient. The starry sky appearance may or may not be appear on the bone marrow. And I'm not seeing, these are just fat spaces here, but we're not seeing the typical tingible body. Maybe we've got some over here for this particular patient. But usually it's just a monomorphic infiltrate of these medium-sized cells. And here is the characteristic c-MYC translocation with 814, which is present in 80% of these patients, and then 20% can translocate with the light chain kappa or lambda, which you would need to, if you don't have a karyotype, would need to do a MYC break apart probe to pick up. I'm going to move on now to Hodgkin's. We said Hodgkin's was the third most common in our setting. And in fact, again, this is something which is picked up commonly in the hematology laboratory. Well, it was when we were doing a lot of bone marrows in these patients. These days, I think a lot of centers are performing PET scans to check for bone marrow infiltration rather than bone marrows. But this is a study which Dr. Luan Swart did for his MMed, looking at a time frame from 2005 to 2012, and looking at Hodgkin's lymphoma and the marrow and the effect of bone marrow infiltration. So there was a large cohort, 219 patients, and of those 82, so 37% had bone marrow infiltration. And you can see that in HIV negative patients, about 28%, so still a very high proportion had bone marrow involvement, and in HIV positive, 61%, which is really quite remarkable. And about 60% of these patients, 61%, were on antiretroviral therapy at diagnosis. Again, this may have changed if we were to do a similar study now, because now we know that we've got about 80% or so ART coverage. And what is important to note here is that in this study, we actually found that almost 20% of this HIV cohort had laboratory confirmed tuberculosis in the 3 months prior to Hodgkin's diagnosis. So either on the sputum or by some other method on a lymph node, aspirate, whatever, they had TB. So the point is, even if the clinicians are finding TB, it's important to look even further and to check that there is no coexisting lymphoma. So this is the picture, the typical picture that we see in a patient with bone marrow involvement with Hodgkin's lymphoma. These are the typical Reed-Sternberg cells in an inflammatory infiltrate composed of plasma cells and small mature lymphocytes, and there are some fibroblasts, quite fibrotic, and typically these would stand up with CD15 and CD30 in a membrane and Golgi pattern, and the LMP1 works very nicely. This is a stand of the latent membrane protein of Epstein-Barr virus, and this stands up the cells which are invariably EBV co-infected in HIV-associated Hodgkin's lymphoma. And the reason I use latent membrane protein instead of EBA is that it's actually about, I think, about a quarter of the cost of EBA, and it works very nicely. And it for this particular HIV Hodgkin's, the stage, the lifestyle stage of Epstein-Barr virus does stain up with latent membrane protein. So just to bear that in mind. Okay, so plasmablastic lymphoma. Plasmablastic lymphoma was originally described in the oral cavity of HIV patients. It's associated with immune suppression, other types of immune suppression other than HIV as well. It's very aggressive, rapidly grows, causing ulceration, bone destruction. And these cells typically have a plasma cell immunophenotype with MYC overexpression and EBV positivity. And this is an example of a bone marrow. It's not commonly diagnosed on bone marrow biopsy, but we have had a few cases. And this is one of them. This was a patient who was on antiretroviral therapy with a CD4 count of 243. And top left is the plasmablasts, which are much larger than normal plasma cells. The nucleus has become more central. It's less eccentric, but still very basophilic cytoplasm. And on the trephine, a heavy infiltrate of these plasmablasts, which are staining beautifully positive for MUM1 in the nucleus. They have a high proliferation index. This patient only had weak CD138 positivity and strong EBA positivity, confirming the overexpression of or infection with EBV. We didn't do a MYC in this particular case. And I just want to show you the typical, so plasmablastic lymphoma really has quite a spectrum of aberrant markers that it can pick up. Janique Bailey prepared this very nice table of which basically looked at all the articles on plasmablastic lymphoma to try and work out what proportion were positive for which markers. So the plasma cell markers, the most frequently positive, almost 99%, is MUM1, followed by CD38 and CD138. And then you can see 70% are EBA positive and about just less than half MYC positive with negative. They're all negative for HHV8. What about other plasma cell abnormalities, malignancies in HIV? So myeloma does have increased prevalence in some HIV studies. The myeloma has been shown to occur at a younger age, and the patients have a high proportion of end organ disease in HIV. They typically present with high CD4 counts and an IgG-M protein, and of course must be distinguished from the very common reactive plasmacytosis, which is present in around 30% of these patients. And this was published out of Bloemfontein with Professor Lowe and colleagues in about how many years ago? About 6 years ago now. So other malignancies, as patients with HIV are living longer due to improved care, taking antiretroviral therapy, the incidence of other malignancies has increased. So this includes rarer hematological malignancies like peripheral T-cell lymphomas and NK lymphomas, to the solid organ tumors that were mentioned in that article, by that table from the New England Journal, cervical cancer, lung cancer, hepatocellular carcinoma. Remember that HIV can accelerate the progression of these co-infections, which is what is increasing their incidence. And again, these can also present with lymphadenopathy and cytopenias. A leukoerythroblastic picture is highly suggestive, but not at all specific of bone marrow infiltration. And conversely, a leukoerythroblastic picture is present in less than 50% of patients with bone mets. So although it's helpful, it's not always there. And in adults, the bone marrow is a common place for solid tumors to metastasize to. And just to show some quick pictures of what metastatic malignancies can look like, typically with these very tight bundles of malignant non-hematopoietic cells with nuclear molding. Although this one, which is a cholangiocarcinoma, they are actually quite separated out. So very important to look for those under low power on the bone marrow aspirate, because there may be very few of them. Multicentric Castleman's disease is a lymphoproliferative disorder with increased incidence, markedly increased incidence in HIV, but it's polyclonal. It's between a reactive and a malignant condition, and it is associated with excess cytokines, particularly interleukin-6, which is driven by the human herpes virus 8 infection. It can be seen on the bone marrow. Not common. We've had a few cases over the years. Typically, you would have a lymphoid aggregate with a cuff of plasma cells, which are expressing lambda positivity. So, oops, sorry. I'm just moving my. So here we have the C is for the CD138. So that's standing up the plasma cells, lambda in D, kappa in F, and HHV8 may just only have 1 or 2 positive cells with this stippled nuclear staining. Kaposi sarcoma, I need to mention because it is, you know, that slide showed there's 500-fold increased risk of Kaposi's even in patients on antiretroviral therapy. I myself have never seen a case in the bone marrow. It does happen. This is what we'd be looking for. Vascular tumor with cells of endothelial origin that would be CD34 positive and HHV8 positive. And this is a picture from Barbara Bain's bone marrow pathology. So, been through all the complications that these different conditions can present with and how that can involve the bone marrow. So what about recommendations for bone marrow biopsy? How do we go about recommending bone marrow biopsies? In general indications would be if there's lymphadenopathy or a mass unsuitable for biopsy. The chest X-ray or CT scan suggests tuberculosis or lymphoma. There are unexplained cytopenias or B symptoms, and by unexplained, need to go through a logical process of excluding common causes for the cytopenias. An unexplained eucharythroblastic blood picture, especially with teardrops, but it may not be present. And of course, blasts or lymphoma cells on the blood smear. They should have routine stains performed. We recommend that all have fungal and mycobacterial cultures. We collect a sample for flow cytometry, which can, of course, be discarded if it's not needed. And we perform 2 unilateral posterior superior iliac spine cores with a total length of 25 millimeters. And so this saves doing ipsilateral, so marrows from 2 different sides, just making sure that we have the correct length. And one of the previous registrars who's now working in Australia, Leanne Phillips, she actually did this as her MEd project and showed that it's actually the length, this is the sort of cut-off length that we should be working for in order to have the maximal chance of picking up lymphoma in the marrow. And this is just an interesting, I know that there's some discussion amongst our clinical, with some colleagues to say, you know, should we really be doing bone marrow cultures, especially with austerity measures in the state sector? We've got to think about every penny that we're spending. This is, again, it's another, an old study, which Willy van Schalkwyk did, and we did this with Prof. Nowitzki, and in that stage, it was even less that were on antiretroviral therapy, only 25%. But we found that the bone marrow, this is for patients who had cytopenias or fevers, that we could actually make a unique diagnosis on the marrow, most typically with mycobacteria. And what I wanted to show here is that there was a proportion where there were 1 or 2 patients where, in fact, the culture came back positive, the aspirate culture came back positive, and there were no granulomas, and vice versa. So they do complement each other. Okay, and then last point is the coagulation abnormalities in HIV. We know that HIV is prothrombotic. There's an increased incidence of arterial and venous thrombosis. the venous thrombosis is increased up to 10-fold, depending on which article you read. They have an increased risk of CDAs or strokes. And we know they have increased von Willebrand's factor with reduced natural anticoagulants protein C and protein S. They also have endothelial cell dysfunction due to chronic inflammation, platelet activation, and coagulation activation. And the highest risk is with advanced disease, coexisting opportunistic infections, and or malignancies. And colleagues in Johannesburg, Prof. Shapritz, has shown that lupus anticoagulant positivity is associated with increased risk of venous thromboembolism in HIV. So I've done a bit of a whistle-stop tour of hematological complications of HIV this afternoon. We've come to the end. I hope I've given you just an idea of where we are and what the spectrum of disease is. And I'm just finishing with some beautiful flowers from our Western Cape fynbos, which you can find if you go hiking or trail running up in Table Mountain. Thank you very much for your attention.
Thank you very much, Jessica. Yeah, that was indeed a whistle stop, and I've personally learned one or two new things in there.
Oh, I'm glad.
My advice to the registrars is they get hold of your review. I did see it, the last review that you did. In there is most of, like Jessica said, what you discussed. And there is that figure which you shared, which you propose how to approach. That's figure 1 in your presentation. That's precious. I would really recommend that some of our colleagues keep it for ease of reference. There are some comments and a question. The comment is from Vernon, who's happy that we've got local studies in there. And the second one is a question from Johan Potgieter. He says that we often get disappointed with the glycophorin stain to show the erythroid nature of the cells, some of the cells. Now, does CD71 immunohistochemistry work for you?
I personally haven't used it because I haven't had trouble with glycophorin. And in fact, I have noticed fewer of these bone marrows that have been requested for patients with parvovirus. So I'm interested to hear, Prof. C, your experience or others' experience, but I myself have been happy with our glycophorin stain. Of course, they differ from, they're different antibodies and different types of stains, different manufacturers, etc.
Yeah, what I can say is over the years, I've found glycophorin to be quite finicky. It's not an easy stain at all. So let's hear about comments on, maybe someone has got experience with CD71 immunohistochemistry. From our team here, can I call upon any one of the consultants, please, chip in on the
Hi,
use.
Prof. It's Erica here.
Hi, Erica. You're echoing very nicely.
Sorry about that echo. I just wanted to let you know that we're also using glycophorin routinely. We don't have that much of an issue with it. We haven't been using CD71.
Good.
But I will also add that we send it to Grooteskier, so it's likely that Prof. Opie and I are looking at the same stain.
Of course you are. All right, so look, Johan, it sounds like down here our setup works very well for us, so we don't have any cause. But I would really urge people to look at CD71. When things go wrong with glycophorin, it's very difficult to fix the problem, and we need a plan B. So who uses CD71 IHC? Anyone in the audience? Viz?
I think it's being used at Wits.
Yeah.
Z.
Vince, your experience with CD71, anyone? Well, we don't have, well, I'll pencil that in and we'll look into it. Because we also need it as a plan B, just in case something happens to Jessica, then we can do it on our own. Good. Any more questions, folks? I'm just trying to look at the chat. In the chat, Isam Mahrouj says that the E-cadherin is a good one for early erythroid, and Dr. Grewa agrees. I haven't seen the earlier questions. Are they? Maybe just unmute and ask your question if you haven't raised your hand or if you haven't typed it in. Anyone?
Hi, Lee.
Yes.
It's Johan again.
Hi,
So,
hi.
so the question is, just a comment. Our CD or the glycophorin works perfectly well, but it identifies the earlier forms and not the or the later forms and not the
Later,
earlier
yeah.
forms. Yes, and often we are convinced that those are erythroids, but it doesn't demonstrate that if we would like to stain that. You know, so and we will check in on CAT here and certainly also on 71. The other question that I'm having, Jessica, so both you and Z's research groups have shown dysplasia, multi-lineage and single lineage dysplasia in your marrows to the tune of about 60%. What I would like to know is people with HIV also can develop myelodysplastic neoplasms. And what is the approach to identify that? Is it only going to be molecular studies, or how do you go about showing that? Because we say that there are confounding effects of the cytopathy of HIV, and it's difficult to basically pin it down. Your comments, please.
Well, I can comment, Johan. Thanks for that. That's an excellent question. The first point is if there are blasts, this is not an HIV dysplasia. So if there's any increase in blasts, we need to be thinking about actually a myelodysplastic neoplasm. And in that setting, I would be requesting cytogenetics, plus minus NGS. We have to send it to Johannesburg from here. But the first thing that would alert me would be if there were any increase in blasts. The second thing would be the depth of the cytopenias, and if the patient hasn't responded to, the antiretroviral therapy, and to check that there's no opportunistic infection, checking the other drugs, the cotrimoxazole, everything's been reviewed. And usually these patients would need a second bone marrow biopsy. So in a patient where there's, significant dysplasia and, if they're not on treatment, it's usually we will say that they must start treatment, and if it doesn't resolve, then we would recommend further investigations for dysplasia. But generally, I mean, if it's only cytopenias, then we really have to follow a similar workup to a patient without HIV. It's very difficult. There are no sort of set rules.
Good. Nothing to add to that from our side. Anyone wants to add any further comment on that? I think. Great. Any more questions on the chat or in the house? Right, then it looks like we are done. Organizers, do I need to do anything or is this it?
Hi, Prof. No, I think you can close. Thank you.
Thank you very much, everyone. See you soon.
Thank you very much. Thank you for cheering, and thank you everybody for your attention. Enjoy the afternoon. Thank you.
Thanks
Thanks
very much.
everybody. Thanks Z. Thanks
I
Jessica.
enjoyed it.